You are looking at Chicago, and we are at the 2016 ASH meeting on hematologic malignancies. One highlight is most certainly the opportunity to hear world-class experts in hematologic malignancies discuss the latest developments in critical care, specifically how they treat their own patients based on the available data. So this time around, I'm with Dr. Joseph Connors, who is an MD. He's from the British Columbia Cancer Agency, where he's clinical director of the Center for Lymphoid Cancer, and also in Vancouver, of course, and a clinical professor at the University of British Columbia. First, thank you very much. We're chatting here about how I treat Hodgkin lymphoma. So let's start with what you were trying to get across in this particularly good session.
Well, Hodgkin lymphoma is a quite special type of disease or malignancy in that we've been reliably able to cure patients of this disease for decades of time. So early on, the challenge became how to do that at the same time as we keep an eye on late toxicity and irreversible damage that we do to the patient in the course of getting rid of their Hodgkin lymphoma. And a balance does need to be struck such that we cure the most patients, but that we hurt as few as possible, especially in terms of long-term complications. And that's the focus of research in Hodgkin lymphoma and the way I tried to configure my talks today.
So the standard management of limited and advanced stage disease, what are we looking at today?
In broad terms, today we can take advantage of a collection of diagnostic improvements, so the diagnosis is quite accurate, and in evaluatory procedures such as functional imaging. So for limited stage disease, a brief course of chemotherapy nicely addresses hidden systemic disease, and consolidative radiation in selected patients can be the right thing to do, and the functional imaging guides us to which of those patients should have it. Advanced stage disease requires a longer course of chemotherapy, but the concept is the same. We sort out, after the chemotherapy has been delivered, using functional imaging, which patients also require consolidative radiation. And those packages of treatment nicely strike the balance I was talking about, holding toxicity to a minimum, but optimizing therapeutic outcome.
You also address the most effective approaches to managing relapsed lymphoma.
Yeah, Hodgkin lymphoma does relapse some of the time, fortunately only about 1 in 5 patients. And there we're additionally fortunate in having a technique, high-dose chemotherapy and autologous stem cell transplant, to address that relapse with an overall 50% likelihood of curing the disease. And so you get a good second chance if you put the package together correctly.
Now, you recently published in Blood 5-year survival and durability results of brentuximab vedotin in patients with relapsed or refractory Hodgkin lymphoma. What did you find in that particular 5-year review?
Well, the importance of that study is that with a disease in which we're already successful, the challenge of building on that success and making further improvements can be substantial. And recently, we're fortunate in the development of a monoclonal antibody drug conjugate, brentuximab vedotin, which delivers effective treatment to Hodgkin lymphoma with a minimum level of toxicity. And so since its development, we've been working out when is this going to be most useful. The first test was to see if it would work in patients that have already had multiple treatments, and now the disease is back and we need to do something about it. And these 5-year results are quite gratifying in that many patients did respond to the brentuximab, but most importantly, a small fraction of those patients have still remained in remission more than 5 years from the time when they received the brentuximab with no further treatment. And so somewhat remarkably, a single drug has been able to cure doubly resistant Hodgkin lymphoma. And of course, we want to use that agent earlier in the course of the management of these patients, but that pivotal information is equipping us to ask those questions.
Well, you mentioned timing. You also recently reported the impact of treatment delays on outcomes in Hodgkin lymphoma. What did you find in that one?
We didn't find anything surprising. I think it is clear that for all malignancies, delay in correctly diagnosing the disease eventually accumulates to the point where the prognosis changes. The tumor burden rises, the likelihood that disease resistant has evolved emerges, and those delays put the patient at greater risk of the disease relapsing despite our best treatments. And we confirmed that same finding. Fortunately, there is some time if one gets on with the process of assessing the disease within weeks or even 1 or 2 months of the initial appearance of symptoms. Nothing seems to have been forfeited. There's time enough to work in that interval. But if you get out to multiple months of delay between onset of symptoms, then it's clear that the prognosis deteriorates. And it puts a premium on correctly diagnosing the presence of these malignancies.
When you were done talking about how I treat Hodgkin lymphoma, what was the discussion? Were there some questions or were there some concerns?
The questions were on the focus that I was mentioning, and that is, how do we deliver these highly effective treatments while minimizing the risk to the patient? So we asked questions about the individual drugs. When are drugs not to be used because their danger has risen? There were questions about the appropriate timing of the diagnostic tests. When should the PET scanning be done to minimize false positives and separate out the true positives? There were questions about the long-term follow-up of these patients and how best to think through how they should be monitored on into the point in time when they very likely have been cured. All excellent questions from practicing clinicians who need practical answers to real problems.
Well, I really like this meeting because of the how I treat core of the program. And you're co-chair of the meeting, so congratulations. I think this was well done this year.
Thank you very much. It's been a pleasure to address this audience.
And for ASH Clinical News, we have a variety of coverage in the book as well as here online, so please check out both. And for American Medical Communications, I'm an executive editor, Rick McGuire.